My name is Mark Tatangelo. I have a PhD in health services research with a specialization in musculoskeletal sciences from the University of Toronto. Right now I'm a researcher at the University Health Network and also at the Institute for Clinical Evaluative Sciences in Toronto, Ontario. I'm also a senior health analyst in Toronto, Ontario. My role briefly is I design and conduct research studies with a focus on population administrative data. My goals are to use health data to help with healthcare resource planning. My research specializations are observational cohorts, statistical research methods. Increasingly, I've been focusing on computer-assisted decision-making in healthcare, and also prediction and automation using software. So the background work for this particular study, when I began my PhD, often the first thing that we do is to conduct a systematic literature review. And when I conducted my review of comorbidities in rheumatoid arthritis, this is usually considered one of the bigger questions in the disease. There was a large volume of published materials, but I also found a large variability in study design, quality of methodology, and standardization between studies. So there were really big differences between the different studies on comorbidities. And what I realized was that there was a limited amount of long-term, high-quality population data where all the comorbidities of rheumatoid arthritis were examined before and after diagnosis. And again, just to go over again, what I really noticed was that the research methods that were being used were not adequate. They weren't strong enough to measure causal attribution. So what does that mean when we talk about causal attribution? It means that how certain are we that a comorbidity of RA is actually related to the disease itself? So looking at the literature, we can see that the methods that are being used or were being used weren't, I would say, appropriate to actually make that distinction as to what comorbidities were related to RA and what comorbidities were underlying or occurring irrespective of the disease diagnosis. So we used a longitudinal matched cohort study design, and we included patients who had an RA diagnosis in each year from 1995 until 2015. And what we did was we matched each RA patient to a patient who didn't have RA and was also alive in the same time period. And what was interesting about our match was we actually used two separate control groups, non-RA control groups. The first control group was matched only on age and sex, but the second control group is the really innovative one, because what we did was we matched on age, sex, but also on pre-diagnosis medical history. The reason why we used two control groups was because the use of multiple control groups let us separate the directly attributable comorbidities of RA and the indirectly attributable comorbidities of RA, and also let us separate the underlying age and sex-related conditions that I mentioned before would have occurred irrespective of an RA diagnosis. So there were many findings. Again, it's a complex topic, but to summarize our main findings, we found that the RA patients have more comorbid conditions compared to non-RA patients. And interestingly, these differences were detectable before the diagnosis. The comorbidities peak in the year of diagnosis, but we then see a decrease in comorbidity after diagnosis. In terms of attribution, we found that approximately half of the attributable comorbidities were directly attributable to RA. We also interestingly found that in the pre-diagnosis period, the indirect effects of RA are observable, but the direct effects of RA manifest after the diagnosis. So that's something that we would expect just with an understanding of the disease. We found that most of the comorbidities are low and medium severity. And then the final finding that I'll mention is that we found that RA patients who are diagnosed in later calendar years appear to have less comorbid conditions compared to patients diagnosed in earlier calendar years. I would say that surprising differences in individual comorbidities across the spectrum of disease were occurring. So we found systemic differences in many comorbid conditions, really highlighting and reinforcing the systematic risk of inflammation brought on by rheumatoid arthritis. We also thought that the differences in comorbidities from the time of diagnosis was interesting. So the decrease after diagnosis showing a possible effect of treatment and improvements as a result of treatment. And finally, I would say that we were surprised to see how early the observable differences between RA patients and non-RA patients occurred. That was definitely an interesting finding for our team. So some of the sharp rise is attributable to the accrual method. So because it's an administrative study, you need to have interactions with the healthcare system to actually be identified as RA. But even controlling for those identification increases, we can see that RA patient healthcare utilization becomes more intense at the time of diagnosis, again, likely due to an increase in unexplained symptoms and patients seeking a diagnosis for the disease. And a sharp fall immediately afterwards, again, we know that early aggressive treatment are effective treatment strategies for RA. So we are hoping that this is showing the benefit of treatment. So a reduction of healthcare resource use and a reduction in comorbidities brought on by treatment and identification of the disease. So we tried to get at this aspect by looking at the diagnosis year. And I'll say that there are many care improvements brought on in recent years for RA patients, like early aggressive treatment strategies, the early use of triple DMARD therapy, which could all be explanations of the effect of later calendar years having more decreases in comorbidity after diagnosis. However, there's certainly a component suggesting that new treatments like biologics and JAK inhibitors for RA are at least partially responsible for these improvements. We did note in our study window the substantial increase in the use of biologics because 0 patients had biologics before 2001. And by 2015, we had at least 30,000 estimated users in our cohort. So it's certainly one of the explanations for a decrease in comorbidities over calendar time. Our results suggest that RA patients show detectable patterns of care use. And for clinicians, when a patient shows up in their office and has a diagnosis, often one of the first questions I feel like I've heard from patients is, what does this mean for my life and what going forward can I expect? And the nice thing about these results is it really gives physicians the data to say to patients, here are the different systemic risks of RA. You can expect a certain increase in heart conditions, lung conditions, and they can give those percentage risks to patients. And they can tell them that, well, they can confidently say that this diagnosis period is likely the worst for comorbidities that they're going to have, and it will likely get better. So they can not only talk about long-term disease trajectories with the patient, but they can also discuss the disease-specific risks conferred by this diagnosis. Not to scare patients, but just to give them a realistic idea of what the disease is actually going to be like. So we detected the differences in comorbidities with a large database and the collection of many data sources together. So we used hundreds of thousands of observations, but clinicians and patients dealing with an individual case may only see a small portion of the medical resources used, and they don't have access to this kind of large hundreds of thousands of person sample to directly make predictions or make care decisions with. However, our results do suggest the possibility of a patient or clinician to pick up the early telltale signs of RA or be on alert for these symptoms. So in the future, clinicians and patients who have a high probability of RA, given the past medical history, we could be using computer predictive tools to actually alert a patient or give a recommendation based on a patient's risk profile that could tell a patient that they're more at risk for certain types of comorbidities or negative events. So I would say we have to walk before we run. The first step was to define the disease, but as time goes on and as our technology gets better, we should be able to move into more assisted decision-making for patients and clinicians with this disease. I don't think that's out of the realm of possibility. I wouldn't call it fanciful. I would say that our results do suggest there is data to say, at least at the population level, that predictions could be made about a patient's future risk of acquiring RA. And if those predictions were possible, medical ethics dictates that you should at least ask a patient if they would like to know about this increased likelihood of a disease. So today we don't have those predictive engines to do that, but I do think it's certainly possible to create something that would do that, and I do believe it would provide utility for patients, and that if such a prediction could exist, that patients would want to know about it, and there would be utility in telling them about this kind of increased risk. Now, again, there may be uncertainty in this prediction, but I think that in patients who have a risk of developing a chronic condition, just to know to look for the symptoms could help with early treatment or with early disease recognition, improving outcomes for the long term. So the study methods were unique in healthcare, but very common in industrial engineering and error reduction. So the use of distance matrices is starting to be realized because we have more powerful computer hardware and also software. Our strengths of the study because of these methods were lower susceptibility to point in time bias. So that's measuring patients at different points in calendar time. We actually controlled for those differences. We also achieved a stronger predictive probability for patients. So we match patients with similar disease histories more closely than prior studies. And the result of these methods improvements overall means that we could be more sure in our study that our comorbidities were attributable to RA. So we were more sure of our causal attribution mechanism because we had an increase in predictive performance of the methods. So the methodology used is very versatile and has a diverse set of applications. We actually applied the exact same design methods for another study looking at RA attributable healthcare costs. And I will say that the methodology is limited only by the person's data and imagination. Any disease or application with a set of prior data, a definable high quality exposure definition, and measurable follow-up data could be used or is a candidate to use distance matrices, which is the method that we used in our paper. Our team is looking at other applications, like focusing on individual level comorbidities and also increasingly focusing on the pre-disease histories of the patients. This is a really difficult question to answer because our healthcare services databases in the entire world, not just Canada, they're always 2 to 3 years behind today's date, and 2020 is not over yet. So we won't know the full impact of COVID-19 on RA care until 2022 or 2023, once all our data is actually in from these databases. However, we can see huge impacts, both negative and some positive, from the COVID-19 pandemic. Anecdotally, across the world, clinic hours have been reduced, but this has led to a rapid uptake of telemedicine. So there's certainly a double-edged sword there. I would say that patients with rheumatoid arthritis and all patients with any chronic disease, they have been overall, I would say, negatively impacted by the COVID-19 pandemic because of understandable human and material resource limitations that no one wants, but that are the realities of a global crisis. I do hope that all patients with RA are able to access their medications, general and specialist care, and that they remain healthy during this time.